Okay, so before we get going, I just want to welcome you, everyone. Thank you again for joining our virtual Zoom event. So my name is Sally Chen. I don't think you know me actually. So I'm the Digital Health Research Coordinator from BC Children's Health Research Institute and Women Health Research Institute. And I want to give everyone a chance to also have a look. I was muted somehow. So feel free to watch other past seminars at your own time. And before we get going, I want to acknowledge that we operate on the ancestral and unceded territory of the Coast Salish people, including, the territory of the Musqueam, the Squamish, and Tsleil-Waututh Nation. So we recognize, their ongoing contribution to the health and well-being of the community. And I also want to express my respect, and gratitude for the opportunity to live, work, and serve on this land because of them. It is crucial that we honor and support the rights, culture, and history of Indigenous people as we work towards reconciliation and improving healthcare services for all of us. So it's important to remember that. Okay, so without further ado, because we only have 1 hour today, we have 3 speakers today, and it is my pleasure to introduce our first speaker, Dr. Alexandra Kitson. So Dr. Kitson is a postdoctoral fellow at Simon Fraser University, working within the Tangible Embodied Child-Computer Interaction Lab. So her work centers around collaborating with community stakeholders to design, develop, and evaluate digital well-being and mental health technology. So by leveraging technology like wearable and mixed reality, Dr. Kitson aims to enhance accessibility to mental health support system while also empowering diverse population by acknowledging their expertise as individuals with unique lived experiences. So without further ado, let's welcome Dr. Alexandra Kitson to our seminar as we want to know her opinions about the intersection of VR and mental health. I'm going to stop sharing my screen. And I'm going to center you, Alex, if that's okay.
Great. Thank you, Sally.
Thank you. You should be able to share your screen. Yeah, we can see it. Perfect.
Okay, great.
Yeah.
Oh, thank you everyone for being here today. Today I want to go over what virtual reality is, what makes it a unique technology compared to other forms of media, with some examples in healthcare. Then I'll talk a bit about my research and how I go about designing and developing mental health and well-being interventions. I'll talk about 3 of my projects and then some open questions that I have for the field. So, show of Zoom hands. How many of you have tried virtual reality before? Yeah, I'm seeing a lot of hands in Zoom. That's wonderful. Quite a few. So for those of you who may not be familiar, virtual reality, or VR, is a computer-generated 3D environment that allows the user to experience a simulated world through stereoscopic 360 visuals, stereo audio, and 3D interactions with tracked sensors. You can experience and see the world around you. It's a very visceral experience. It feels real, even though you know it isn't real. So it's kind of like a very vivid dream. I'm just seeing this overlap on my screen. Just better. Okay, so what is virtual reality? All these other terms out there: augmented reality, mixed reality, extended reality, metaverse, all these different terms are being thrown around, but what are the differences? Well, VR is a completely digital experience. So compared to our non-computer generated environment, or what we would just call reality, VR is completely computer generated. Augmented reality is taking the real world and overlapping digital content onto it. And then augmented virtuality, which is a little less known, is when you use the real world and its objects to influence a purely digital experience. So you can kind of think about it on a continuum. Today, I'll talk about virtual reality, but I'll also mention some mixed reality experiences because it's becoming more and more prevalent too. Three main concepts that are important when talking about virtual reality are immersion, presence, and embodiment. So immersion is surrounding your senses, what you see, hear, and touch. We think of this as kind of properties of the technology. The technology surrounds your senses. It immerses you. Then presence is feeling like you are there. So you have this kind of psychological understanding that you are in the space and there are objects there or other people. And then embodiment is your awareness of your body and moving in 3D space. So all three of these together are what make virtual reality a sort of unique medium and technology. What year did virtual reality start? Any ideas? Can put it in the chat. What was the first instance of virtual reality? Let's see. 2000, 2010, 1952, the 80s, all great guesses. The concepts of VR have been around for actually a really long time. So even way back in the day, people were making 360 panoramic paintings, and the idea was to totally immerse the viewer into the painting and feeling like they're really there. Then we have stereoscopes. In 1838, this was presenting a slightly different image to either eye. These two images combined in the brain to give you a perception of depth. Then we have in 1929, the Link Trainer, which was the first flight simulator used for training pilots. Then in the 80s, we have the first sort of headset that changed optics of still images to make them appear 3D. And this was sort of what we think of virtual reality today. Then in the late 80s, the term VR is coined. And we have these head-mounted displays, or HMD, things you put over your eyes like goggles. And we also have these virtual reality gear like the Data Glove already starting. Then video game companies started making virtual reality headsets as well. This is the Nintendo Virtual Boy. It was a total flop and failure, and it kind of put a lot of people off of virtual reality for a while. And then it wasn't until 2012 when we saw the Oculus on Kickstarter, where they promised a much cheaper and accessible version to other VR systems, which at the time costs tens of thousands of dollars. And then Facebook bought Oculus for $2 billion. So now we see VR has come a long way, even in the last 10 years. I can't believe it, actually. We have untethered headsets, we have hand tracking, haptics, brain-computer interfaces, augmented reality glasses. But this didn't happen overnight. It was decades of innovation and technological advancements. Here's some more examples of kind of virtual reality-like things like the Cave stereo displays. We have augmented reality glasses and now the Apple Vision Pro mixed reality headset. So there's been more than 30 years of solid research in applications for VR in PTSD, anxiety, acute and chronic pain, obesity and eating disorders, physical rehab, and more. So VR is safe and effective when it's based on science and clinical practice. And if you add gamification, it can also be really fun. and it can deliver good health outcomes. Maybe it's not better than our existing things, but it's just another tool that we can use to help motivate patients or do things in a slightly different way. So we need all these things: neuroscience, psychology, computer science, engineering, design, storytelling. It all comes together and it's very multidisciplinary. So I'll show you some examples of VR in healthcare. Here is the interactive medical training.
It's very beneficial to use guides in this kind of times, because if you know that tomorrow you have to go to the ICU and it's your first shift there and you don't know what to do and you don't have time, and maybe you're afraid to say that you don't know how to operate a device, it's easy. You can use guides and learn by yourself how to do it.
And also in specialized care and collaboration, you can bring in experts.
So when you place the headset on your head, what the user will see is a virtual screen or a mixed reality screen, which they can position into any real space in the room that they're standing in. And on that screen at the moment will be the face of one of their colleagues who will be interacting with that user through a webcam based on a desktop. We can call other experts that we might want to call into that clinical scenario. And we can also pull up images and content. So we can look at electronic healthcare record data or x-rays or images.
And not only for healthcare providers, but you can also use it for wellness with patients as well.
So virtual reality for us is something new. It is something that we're going to encourage our care providers to become involved in and step away from the bedside for 20 minutes to breathe and walk through this tranquil, beautiful setting, and how can they help themselves get through this next 12-hour day or whatever it is.
And then here's a picture of a patient using breathing biofeedback with virtual reality to help relax. VR is also used in exposure therapy. Here's one.
There's a dog with you there, and you can, with your hands, you can almost touch it, and you can walk around a little bit. If you move your body, you can see you can move around it. Yeah, exactly. And the whole point of therapy is to help you face your fear, in this case, fear of dog. The key thing when you face your fear is not avoid. So I want you to progressively try to do things you would be afraid to do. Exactly.
So there are hundreds of different virtual environments that can be used in exposure type therapies as a tool. VR can also be a kind of distraction.
See how it moves?
Yeah.
So reach, you see the big ones look like a star? Try to poke that one.
The most important thing that kids can do is play, that's their work, and that's how they process things and work through things. And so this is just a great way for them to completely be immersed and escape from the hospital environment and what's going on.
Right, so we're also seeing some VR in children's hospitals as well. So those are just some examples. Next, I'll talk about how I go about designing and developing these kinds of interventions. Looking at different theories and frameworks, there are a lot out there, and different fields approach it in different ways. As someone who's in a multidisciplinary field, I see things from engineering, psychology, clinical practice, all sort of talking about the same thing and how we can create technologies for well-being, but they're not always connected or on the same page. So part of my work is trying to understand the differences and similarities in some of these frameworks and bring them together. One such way is combining multiple approaches using theory, practice-based experts, and community perspectives. And when we're creating virtual reality for mental health and well-being, that's really important that it's grounded in theory, but also we're consulting with experts to make sure the intervention is viable, and then bringing in the community to have their perspectives and voices heard, so that in the end, it's an experience that they feel empowered to use. Whenever I'm creating an intervention, I think of what is the logic model? What's the input, processes, output, outcome, and long-term impact? Here's one example of like a mobile app for sedentary people. They engage with the feature like a calendar that reminds them to exercise. The output is they exercise as scheduled. They might become less sedentary and over time have improved fitness. So I think it's really important to be clear, what is the mechanism of change in your intervention? And so in this paper, talk about some of that process in terms of interaction design strategies and how you can use theory and use that as design strategies and elements. I've done quite a number of different projects in this well-being and technology field, which you can look at my website. But for today, I'll just briefly mention 3 of those. The first one is about eliciting positive emotions such as awe and wonder, called Odyssey. And this was inspired by the overview effect, which is when astronauts go to space and they look back at the Earth and they feel a sense of connection and oneness with humanity and the planet. And so we want to see how we could recreate that in virtual reality and bring that to more people. So yeah, in this experience, you start off in the forest, you're sitting by the campfire, you can almost feel the heat coming from the fire, sounds of crickets and birds, you see the night sky. You take a walk to your spaceship, you're launched into the sky, you feel the vibrations of taking off. When you look out the window, you see the vastness of space around you. And then out of the corner of your eye, you see the Earth rising. And you're left in absolute wonder and awe. The borders of countries just seem to melt away. And as you go back to Earth and take off the VR headset, you might be left with a sense of deeper connection and appreciation for our planet. So not only can VR elicit these strong emotional reactions by like amplifying that experience, but it can also transfer over to our everyday life. The second project I've done is with neurofeedback and VR together, originally inspired by lucid dreaming. Any lucid dreamers out there? So that's when you know you're dreaming while you're dreaming, and then you can control the dream. And I thought, you know, lucid dreaming is kind of like the ultimate virtual reality, because you can just do whatever you want and just think it and it appears. And it feels real even though you know you're dreaming. So it's like, there's something interesting there. So I interviewed a bunch of lucid dreamers and wanted to understand how they use that for introspection and reflection on themselves, and seeing how I could translate that into design of VR experiences. And here's the final project. Right. And then we did run a short study on that to see what people thought about it. And they did actually use it as a way to reflect on their own mental states. This one quote in particular was interesting. This participant thought it was like a psychedelic experience where they had a lot of fear come up and wanting to control the environment, and watching how their attention fluctuated, and they felt that they were not in control of their mind. But then they learned to recognize that it's just an experience and it's not going to last forever. And if they just surrender, everything is going to be okay. So that was a nice kind of reflection. And the last project that I'll briefly mention is ongoing. And this is on looking at cognitive reappraisal skills development for youth with VR. I'm using James Gross' model of emotion regulation, and specifically the cognitive change part, which is one of the most researched aspects of emotion regulation and is used in a lot of different therapies like CBT. So you might have a situation where you feel really angry and frustrated, and with cognitive change, you don't change the situation or problem solve it or distract yourself. You just change your relationship either to the situation or to your own feelings. But this can be really challenging to do as a teenager. One, you're still developing these kinds of skills that are needed, like theory of mind and executive functioning skills and interoception. So I want to see if maybe VR could be a way to both elicit emotions and then sort of practice these kinds of skills in the system. It's a big project, lots of different parts going on. I'll just talk about the co-design workshops where we are working with youth directly in schools and seeing what they think and what they want to see in this kind of experience. So what are the challenges that they're facing, and then how do they envision VR could support them? So to do this, we did a lot of different workshop sessions over 2 months where we needed to upskill them, both in emotion regulation, but also in VR, because it's such a new thing. And we did body-based reflection techniques. We worked with a drama class, which was very helpful. They're already used to doing this kind of thing. And then we had them do a sort of design fiction where they acted out a scene of their emotional situation and then how they imagined VR could be helpful with that. We also gave them some VR prototypes that we developed, which were a way to also facilitate upskilling them in the kinds of interactions that are possible for VR. And this is because there aren't a lot of examples of cognitive change in VR. There's a video, but you can watch that later. They came up with all sorts of different design values. Most notably, they wanted to connect with others. They liked the physicality of the space. They liked that they could only see it and that it was a safe space for them and that they had control over the environment. Especially the social VR aspects seemed to be really interesting. They wanted to be able to talk to their friends and share different experiences in the space. So now I'm starting to explore VR chat and how youth are using that platform for mental health and well-being. Okay, so where can we go now? Still a lot of open questions in this field. Understanding the mechanisms of change related to VR and its benefits, we don't know yet. Also understanding what are the outcomes and how can we improve those? Where is VR going to be most helpful and where is it maybe not helpful? So, I don't believe VR is like this amazing solution to all problems, but we're starting to explore where it can and where it can't be helpful. And then how do we design that? That is based in theoretical constructs of embodied interaction, but also in clinical practices that we know work. So I think that's my time. So I'll stop there, but thank you so much. And feel free to reach out if you have questions, and I'll stick around after too for questions.
Thank you so much. That's fantastic. We would give everyone a chance to ask questions. So please leave and put your questions in the chat box. And this is Dr. Alexandra's TED Talk show. So if you're interested, you can also go on video and watch her presentation. So, okay, could you stop like share your screen so I can, yeah, okay, perfect. So I'm going to quickly share my screen, and then we are going to invite our next brilliant speaker, Natalie Brown. Natalie is currently a PhD student in UBC Clinical Psychology program, conducting research with Dr. Laurie Broto and Dr. Alan Kingston. She has been involving with a study investigating women's subjective sexual responses to virtual reality erotica, and she is currently evaluating virtual reality as a clinical tool for individuals with genital pelvic pain and penetration disorder. So overall, like, her research program aims to improve our understanding of sexual difficulty and develop evidence-based intervention for individuals with distressing sexual concern. So today we will hear from Natalie about her study on virtual reality exposure for vaginismus. So first, I assume she will tell us what is vaginismus. I'm gonna give the floor to you now.
Thank you so much. I'm going to share my screen and we'll get going. All right. Yeah. So today I'm going to be, so I am, as Sally just said, a PhD student in the clinical psychology program at UBC, and I'll be presenting some of my dissertation work, so virtual reality exposure for vaginismus, a mixed methods proof of concept study. And so I will be starting out by talking about what is vaginismus. So it's a sexual concern that's characterized by this intense fear of vaginal insertion, accompanied by this almost involuntary tightening of the pelvic floor muscles with vaginal insertion attempts. And so affected individuals experience ongoing difficulties with like insertive sexual activity, so penetrative sex. Also have a lot of difficulties having gynecological exams, which acts as a real barrier to cervical cancer screening. And they also have difficulties using insertive period products like tampons, okay? And although prevalence rates are difficult to estimate, based on population kind of community-based studies, it's around 0.4 to 6% of the population that's affected. All right, so available treatments for vaginismus, typically psychological treatments are first line. So you have cognitive behavioral therapy, pelvic floor physiotherapy is also used. Both of those treatments involve the use of vaginal accommodators. So essentially, patients might go for their kind of like CBT session or for their pelvic floor physiotherapy session. And then in between sessions, they'll be invited to insert these vaginal accommodators at home on their own. Now, this really limits the treatment effectiveness for folks with vaginismus. Because although vaginal accommodators are really important in treatment, this population really is marked by avoidance. And so they really struggle to actually complete these exercises at home. And also a common treatment goal for these individuals is the ability to have kind of partnered penetrative sex or vaginal insertion, and the solitary use of vaginal accommodators does not exactly approximate that. So moving on to virtual reality exposure, so VRE. So let's first talk about exposure therapy. So Dr. Kitson mentioned it. And so essentially exposure therapy involves having a patient kind of face their feared situation or object in a kind of like gradual, prolonged and repeated manner. And it's kind of a gold standard treatment for specific fears or phobias. And so it works really well, except for certain situations. So as an example, if I'm treating somebody with aviophobia, fear of flying in airplanes, I would have them first like drive to the airport, right? Maybe sit in the airport lobby and eventually take flights repeatedly. That would be the ideal in-person exposure. That gets really expensive. So researchers came up with a workaround to that, virtual simulations of flights, and they tend to work just as well as real life exposure. And so why would vaginismus be a good candidate for VRE? Well, it has phobic features, right? Folks with vaginismus have this intense fear of vaginal insertion. And VRE would allow for exposure to these feared sexual stimuli, right? To actually like partnered sexual behavior. And there's actually no need for a real life partner, right? They can do it on their own. And so the objectives of my study really was first to determine whether VR sexual scenes would elicit enough fear for effective exposure to occur. In order for like exposure to take place, you have to elicit fear. So would these VR sexual scenes do that for folks with vaginismus? I also wanted to identify VR erotic film features that elicited these phobic responses for that population. Also wanted to evaluate the acceptability of VR for vaginismus. Is coming into a lab, putting on a VR headset and watching VR erotica just too outside the box in terms of a treatment? And also identify psychoeducation that would support future engagement in VRE for this population. So for our more quantitative questions, we hypothesized that folks with vaginismus would experience more distress, fear, disgust in response to VR sexual scenes than controls without sexual concerns. And we wanted to understand whether these kind of negative emotional responses were affected by the point of view of the film. So whether the film was shown from the third person perspective, when it's like you put on the headset and you're watching people have sex with each other across the room, or from the first person point of view, when it's like you're actually in the body of one of the actors in the sexual scene. We also wanted to understand how the type of sexual activity depicted, whether it was penetrative or non-penetrative sexual activity, affected their responses. And so we recruited 40 participants with vaginismus and 40 controls without sexual concerns from the community. The inclusion and exclusion criteria are on the slide. And we use predominantly like social media ads. I also put ads on buses throughout the community. If anybody wants to kind of recruit a specialty sample, that is the way to do it. And we also recruited from the waitlist of patients at the BC Centre for Vulvar Health. And so essentially, interested participants contacted me. I did a phone or a Zoom screen to kind of assess whether or not they had vaginismus symptoms. And then if they had vaginismus symptoms and they also had pain with attempted vaginal insertion, they actually completed a physical exam with our study OB-GYN, Dr. Melanie Altez. She confirmed their vaginismus symptoms, so their fear, and ruled out any other potential cause of their pain. Afterwards, they came down the hallway and completed a VR viewing session with me. So they put on a VR headset. I kind of taught them how to use the controls. I left the room. They watched five-minute erotic films and actually kind of self-reported their like fear, disgust, anxiety, distress before and after. And then afterwards, we conducted kind of a semi-structured interview with them to ask them kind of questions like, you know, do you think this would work for helping to manage like your vaginismus symptoms? How so? What type of information would really support your engagement? And what type of like treatment elements would you like included? So kind of just briefly going over the demographics of the sample. So most individuals were around 28 years of age. As for sexual orientation, majority of our participants were heterosexual or bisexual. Most identified as women, but not everybody. As for racial identity, the majority of our participants were white, East Asian, or South Asian. And most had no previous experience with VR. So this is a pretty intense first experience with virtual reality. So I'll briefly talk about some of our quantitative results. So when we asked like folks afterwards, like when watching the sexual VR videos, were there parts that made you feel anxious, fearful, or distressed? 75% of the vaginismus sample said yes, 25% said no, and those numbers were almost reversed in the control sample. A number of the vaginismus participants, most of them, indicated that they were using what we would call safety behaviors to reduce their anxiety or distress. So like looking away from the actors having sex, closing their eyes. Some people dissociated, it depended. So we're also doing an inductive thematic analysis really to understand the participants' experiences of VR and how we could actually improve the intervention to increase acceptability. And really what we found was that they want to see themselves represented in the stimuli. So in terms of, especially when they're in that first POV body, they really want a body that is similar to their body size and also has the same skin color as them. They'd like a choice in their first POV partner. They'd really like to choose like kind of who they virtually sexually engage with. And they're seeking community. For folks with vaginismus, this is a really, really lonely diagnosis, partially because there's so little accurate information out there about it. And so people actually said, like, are there other people like me? Like, am I the only one who is kind of like this? And so the importance of actually kind of developing like a group therapy option or like some options for connection was important. So we actually just won a CHR Spring Project grant to actually test this using a single case design over a 3-year period. And so essentially, we're going to be testing kind of having individuals come in, and we're going for an exposure model, as in if we can have them put on the VR headset, it elicits some degree of fear, and they can actually kind of work through that fear through repeated exposure, then that's the mechanism that we are hypothesizing. And so we're going to be testing that starting in the fall. Yeah, so thanks to my wonderful team, a project with this many moving parts would not be possible without a really amazing team. And that is me. Yeah, thanks so much.
Brilliant. Thank you so much, Natalie. This is really fantastic. Okay, so because of the time, we are gonna just give everyone, like I said, the time to ask questions at the very end. So I'm going to invite our, third and final speaker, Chelsea Stunden. She has over a decade of experience as a clinical research and evaluation a specialist, and she has like expertise, spans healthcare technology, research and evaluation, and she has led, launched, and published user testing, program evaluation, clinical trial, and surveillance project across diverse sectors. And currently, she is the manager of our research and evaluation at the digital lab within the BC Children's Hospital. So she's currently involved studying in the value and impact of digital health innovation within the pediatric context. So let's give her a warm welcome. Chelsea, yeah, it's your turn now.
All right. I'll just quickly share and then I'll go in. Can you see? Looking good?
Yes.
All right. Sweet.
Perfect.
All right. So thanks for the warm welcome. My name is Chelsea Stunden, and as mentioned, I'm the manager of research and evaluation with the Digital Lab. We're an integrated unit of UBC Department of Pediatrics and BC Children's Hospital. And today I'll be talking to you about how we're using virtual reality to reduce sedation rates in children who are receiving medical imaging. Before I get started, I just want to give a huge kudos to our team and our collaborators and our funders, because none of this work would be possible without everyone's expertise and support. And I'd like to give an overview of what we do here at the Digital Lab. The Digital Lab's goal is to improve the health and well-being of children and their families through digital health and innovation. We work in 3 key areas, so digital strategy and design, engineering and technology, and last but not least, research and evaluation. And we have a lot of technical domains that we're dabbling in, but the one that I'll talk to you today about is virtual reality. Because of all the great presentations earlier, I'm not going to go into too much detail about what virtual reality is, but there's lots of clinical applications that you've seen from the previous presentations, and we work in kind of 6 key areas. The one I'll be talking to you in a hot minute is pre-procedural preparation, but we also do some work in therapeutic distraction. An interesting project that we recently did was with cast removals, where we reduced pain and anxiety in children who were having the cast removed in orthopedics. We also worked in rehabilitation. We have a current project with lots of different departments where we're looking at how virtual reality can improve rehabilitation and exercise using virtual reality for patients who have received transplants. We do a lot of training simulations. Neat recent project that we just wrapped up was in partnership with the RCMP, and we modeled how domestic violence situations would play out in the community so that police officers can better train to respond to those. We also have one of the only, or the only, pediatric 3D printing program in Western Canada. And this is really neat because we're able to model patient-specific medical images like CT scans. And then we can print them or virtually model them so that doctors can engage with the anatomy, learn about kind of rare and complex presentations, as well as practice their surgeries before they actually go into that patient surgery. We can use those for training situations. And we've recently also started looking into how we can use those during consultations with patients so that they can better understand what's going to be happening to them in the surgery. And then also during debriefing, better understand what actually happened if there's any changes during the actual surgery. And last but not least, we do diagnostic support. We use extended realities for diagnostic support. So one of these cool projects that we did was using kind of like virtual scanning of heads and looking to see if we can use that and machine learning to support diagnostic decision-making related to craniostenosis types. And so now I get to the heart of the presentation, and I just like to kind of set the mood here a little bit in terms of pre-procedural planning. So I'd like you guys to imagine that you're a parent of a child who's maybe having some chronic headaches, and you've been going to the doctor for, say, weeks, maybe even months, trying to figure out, where are these coming from, what's happening, how can we fix it? You can't find a result with your family physician, and so you've been referred to Children's Hospital. Now, Children's Hospital provides care for children across BC and even into the Yukon. So you could live anywhere in that catchment area. And that's really important to consider for this project that I'm going to be talking about. So you get this referral and you're really looking forward to finally finding the answer to what's going on with these chronic headaches. And you can maybe just like even put in the chat, how long do you think it would take to get your medical image for this type of condition? Let's see. 1 month, 1 year, 6 months, 6 months. All right, so in BC, it's about 1 to 2 years wait, depending on the type of MRI and what's required in order to get that image. So you can imagine that's quite a long time to wait, try and figure out, what's going on for like a chronic headache and, how can we fix this? And this has been something that's been well discussed in the medical literature, as well as in the news. There's countless articles over the last years about talking about MRI wait times. Why are they so long? And interestingly, in BC, actually, the wait times for medical imaging for adults and children are 2 to 4 times higher than other provinces in Canada. So this is a really, pressing and current issue. And the potential consequences of this are potentially very disturbing, because if you have a serious condition, say you had a tumor in your brain and you're not getting your, scan and diagnosis early, then that's going to impact your long-term consequences. And for a kid, they're quite young, so that can have long-term life consequences. So in our current context at BC Children's Hospital, we have about 4,500 kids who get MRI scans each year. And particularly when it comes to children, there's this option of sedated and non-sedated scans, and that's because really young children specifically have a really hard time staying still and understanding what's going to be happening to them so that they can get a diagnostic quality image. And we see about 45% of children have to be sedated, and 55% are non-sedated. And the costs of this are high when you have a sedated appointment, because you need to have an anesthesiologist, you need to have special nurses, you need to have special care to monitor them before and after they have sedation. And this drastically increases the wait times from months to years. But what's really interesting is that in the literature, we see that you can reduce or convert actually children who are scheduled for a sedated MRI to a non-sedated MRI if they receive effective preparation in advance of their medical image. And so at our hospital, we have this child life program, and that's across the entire hospital, but specifically in the case of medical imaging, what we do is we invite children to practice with a child life specialist in a practice MRI room that looks and feels like a real MRI, and they can practice the experience before they have to go in for a real MRI. And this is kind of like a training experience that they do. It's therapeutic play. So here we have a picture of a child life specialist in the practice MRI suite, and they're getting Buzz Lightyear prepared for an MRI. And so if a child life specialist deemed them likely to be able to be successful in a non-sedated MRI, then they're referred to the non-sedated MRI. They can attempt it. If they aren't successful, then they have to go back kind of in the cycle and get a sedated MRI, which doesn't happen very often. They're very good at knowing who's going to be successful during an MRI. But we were interested in looking at this because children, as I mentioned before, have to travel sometimes really long distances, take a time off work, off school to come in for these practice sessions. And that can be a limiting barrier for people receiving this care, and then potentially just have to be sedated because they can't do the practice. So we were like, oh, can we put this in VR? That could be like a really neat solution for this. And so that's what we did. We created a virtual reality MRI preparation experience. The experience was put into a head-mounted display with a smartphone device, and that was so that we can ship it out regarding and eliminate kind of those limitations to where you're located. And the experience included these different stages. So at first, they received this tutorial. How do you interact with VR? As you heard from some of the previous presentations, there's a lot of people who just like haven't used virtual reality before. And so, what are the different elements you're going to experience and how do you interact with them? They then entered the waiting area at the hospital, the medical imaging waiting area, and then they went into the MRI suite where we taught them about what an MRI is, what are the different parts of an MRI, why do we need to use this, that sort of thing. Then they were able to watch a friend or a peer complete the MRI experience. During that experience, they could listen to the sounds. Child life specialists like to describe the sounds as musical instruments, shoes in the dryer, or telephones. So we kind of use these synonyms to make them a little bit more friendly. And then they got the opportunity to either rewatch their friend do it if they still felt uncomfortable, or they could try themselves. So here they're getting their earplugs in, their headphones on, they're getting the coils on. And then they go into the bore and they have a game that they're practicing to help teach them how to stay still. So this game is one of the really unique parts about our virtual reality experience. So what happens in the game is connected to the phone's gyroscope. So it's monitoring the tilt and movement of the child's head while the headset's on their head. And what the child's trying to do is stay still so that they can hatch the dinosaur. So in the first level, the child's in space, they're completely removed from the MRI environment and they're trying to hatch the dinosaur. As they stay still, the dinosaur hatches. If they move, the game's paused. So once they get through that section, then they move on to level 2. Level 2, they're into the bore again. They're still getting that feedback from the dinosaur. Dinosaur is hatching. They're completing that kind of training process as they stay still. Then in level 3, after they pass that, the dinosaur is completely removed, and this is more akin to what's actually going to happen in an actual MRI. And they're asked to stay still with limited feedback in terms of their movement. So we took this experience and we tested it in a simulated environment with children, and we gave them different types of preparation, and then tested them in a simulated MRI experience. So we recruited about 90 participants aged 4 to 13. We randomized them to receive 3 types of preparation. There was virtual reality. The other 2 groups were standard preparation programs that we give to children at the hospital here. One's a book. It has pictures and activities for children to do with their parents before they come in. And then there's also Child Life, which I described previously. Then we asked them to prepare using their various different preparation programs, and we asked them about their anxiety, the parents and the children. And then in the final part, we also asked them, we monitored also their movement in the simulated scan using something called a mode track. It's like a little headband, and it monitors how they move. to see if they were compliant and would have been successful in the actual MRI. And then we asked them how they liked it, basically. And if they were satisfied, we asked the parents and the children what they thought about it. So the results of this were quite interesting because we found VRMRI was effective for non-sedated preparation. The confidence intervals were quite large for this, but you can see there's no differences between the groups. But in terms of compliance in terms of the movement. But we did find some differences between the groups, specifically in child life. The children reported being most satisfied with the child life group, though across virtual reality and child life, they were quite satisfied. And interestingly, in the manual group where the parents were preparing their child with the book, we found spikes in anxiety before they had to get the MRI, especially in the parents. So there was some stress for the parents in terms of getting the kids ready. And so we thought that it would also be helpful to kind of look at what the costs and the benefits of implementing virtual reality in the real world might look like, to see if it would be useful and worthwhile to further pursue this. We looked at things like travel time, administrative efforts, time off work for parents, and we found the total costs of virtual reality were significantly lower than child life. But as you can see, the costs are very broad, and that's largely due to the diversity in the locations that I was talking about earlier. So you can see as you get further away from Vancouver, there's going to be more time that's required to take off work, more time required to travel to these appointments, more costs associated with that. And so naturally, the costs get larger as you move farther away from Vancouver. So that's kind of where we're at currently with testing virtual reality, and it coming up in the fall, we have kind of worked our way up from technology readiness level 1, where we're doing basic research and looking at kind of principles that we might be able to apply, to testing this prototype now in a simulated environment. So in the fall, we're going to be implementing this in real world clinical trial, where we're going to be looking at how virtual reality, we're going to be shipping it out, and seeing how virtual reality actually performs in terms of reducing sedations and also anxiety in children who are scheduled for MRIs. So we're really looking forward to that, and it's going to be really interesting to see the results and if they match what we saw in the simulated study. And I just wanted to kind of include some of our recent publications of data that I've kind of referenced throughout my presentation today, as well as some other interesting virtual reality studies that we've done and published. And if you're interested in learning more about any of our other technology products or research, you can check us out at bcchdigital.ca, scan the QR code, and yeah, thanks guys.
Thank you so much, Chelsea. That's wonderful, and it's very exciting to know you're gonna expand it in full for the provincial-wise for clinical practices. So before we move to the Q&A, I'm going to just briefly introduce our upcoming seminar. So we are going to have one special event about AI with healthcare. It's about power of AI in healthcare, ethical dilemmas, biases, and groundbreaking techniques. So for example, we know this day the ChatGPT, OpenAI, they hold great promises as transformative tools in healthcare. So, but however, those tools were actually identified actually has serious dangers of perpetuating gender and racial biases, and could deliver incorrect medical diagnosis, and that can cause direct or harmful impact on medical care. So we are going to invite Dr. Leo and Dr. Raymond. They are the ICU physician and researchers from UBC. So to talk about this topic in September. So we are gonna share more details on Eventbrite. So register follow us on Eventbrite and stay tuned. We are going to, okay, so I will stop sharing my screen, and that if anyone has any questions, please feel free to ask.
We do have a couple questions in the chat.
Okay.
And thank you, Chelsea, for responding, but there's a a question about applying these techniques in remote patient monitoring context, which I think was directed to Chelsea, but maybe you could all comment on the opportunity to distribute this kind of technology and care in your different areas versus have it centralized. Natalie, you're nodding, so I'm going to pick on you.
The question was directed to Chelsea. You can go. Yeah, so I think that's, yeah, especially with vaginismus, I think one of the things that I realized a lot of participants coming in had maybe never actually been able to speak to a healthcare provider about vaginismus. They weren't able to access a healthcare provider, or for pelvic floor physiotherapy, one of the more recommended interventions, a number of patients felt really deeply uncomfortable with the idea of somebody else actually kind of like touching their like vulva and vagina. And then on top of that, kind of like the travel times to these like really specialized clinics, like ones in Vancouver, right? In terms of like the ability of VR, I mean, in VR exposure therapy, many companies have it whereby you can actually, as a therapist, you can actually kind of control a patient's virtual environment from like miles and miles away. I just did it with aviophobia the other day. Like I had an individual do that. And so I think that we can do that with VR erotica for vaginismus. And I think that would really increase the fees, like increase uptake, but also would just reduce the absolutely incredible burden of travel upon these people.
And Chelsea, are you planning to mail the kit to kids in your trial? So you are doing it. Yeah.
So that's part of our trial, is figuring out, you know, the optimal way to kind of implement these things. We have a pilot study that's going to be, you know, starting and trying to test out some of our ideas about how we can potentially implement this the best and most seamless way. So we're planning to, you know, ship them out to the participants. One of the cool things about having it on a smartphone device is technically, if you had a VR headset, which are pretty cheap, depending on, you know, cardboard headsets are not very expensive, but we use something called the Merge VR, which allows you to kind of adjust your interpupillary distance, which is one of the problems with children because they have really close eye sets, and so it can make things blurry for them. But you can essentially just have this smartphone. You can download it on your smartphone and use it from home. Like you don't even have to you know, get it from anywhere. It can just be on the App Store, for example. And then one of the other things we're looking at is if we can, you know, monitor the data that we're collecting from the game and see if we can use it to predict who will be successful in the MRI. So that's one of the other things we're hoping to look at. But yeah, it'll be interesting to see, you know, how these things work. I think it's a bit of a novel area that people haven't really dabbled too much in. Very exciting.
We are just about out of time, but I had one quick other question because I saw in your presentation, Alex, you integrated the EEG headband. So I think there's great opportunity to integrate digital measures and monitoring as people are using this technology to really evaluate in a real-time way. Have you done that as part of your research?
Yeah, we've been using different biosensors like EEG or heart rate or GSR, and then mapping that to different elements in the environment. It's a little bit different from like just seeing a graph kind of go up and down or numbers. It's a little bit more engaging for people if you want that like kind of closed feedback loop.
Yeah. Sally, I'll stop the recording now if you want to have the final word. Oh, wait, we have one more quick question if you're all willing to stay. Yeah, okay. It says, do you think the credibility of the VR scenario affect exposure therapy results? For instance, if someone doesn't really believe it is real, do they still derive the same benefits?
Yeah, that's a really good point. And that with exposure, especially if it's around phobias, the idea is that you want them to believe it's real. So if they're if you say like, oh, don't worry, like it's just virtual, it's not real, then that's a kind of avoidance behavior that you wouldn't want. So yeah, you do have to be careful with that.
There's also some really interesting research that kind of looks at that, because there's different fidelity headsets. So, you have your smartphone when your headset device, and then there's more higher fidelity experiences where you're interacting with your environment, like an Oculus Quest. There's some new Google devices coming out, and they've shown that the higher fidelity, the more real that it feels and looks, the better that it works. So, but it's kind of this balancing act, because as you get higher fidelity, the devices become more expensive. So you kind of like have to figure out, what's going to be the optimal trade-off for your current or your kind of application case.
Yeah, especially if you want it to be accessible for a broad population and to scale it up and use it pretty widely. You can't have relying on super expensive headsets to bring them out to the community or anything like that. So,
I'd add,
unfortunately, we are getting over time. So we will post this recording for everyone to review, and I think the presenters, I just want to thank you, and I'll hand it over to Sally to close us off.
Yeah, I'm just wondering, like, Vas, there's one more question I think would be beneficial if we could answer. Are there services and devices available for use in mental health and in pediatric health, to your knowledge?
I think that's mostly for you, Alex. Do you know of existing programs in pediatric mental health with VR at this point?
There are some, but it's like I showed example of the Boston Memorial Hospital using, but they're using devices that are designed for adults, and most devices are 13 and up, which has to do with COPA compliance, but you can modify it so it is fitting with children. So there are some out there.
Okay. Perfect. So thank you so much. Thank you again for everyone who attending our seminar today, and thank you for our incredible speakers to give us a topic about the VR in healthcare. Right now it's at 1:04, so this presentation will be recorded, and you can always watch our past videos on our learning corners. So feel free to stay tuned, because our next coming AI is on September 21st. So I'm going to end this recording.